introduce ourselves first, or?
Yes. Is that okay?
Yeah.
Okay.
Yeah.
No, but I will. Is it on the phone? I'll do it during the talks.
I'm not sure if it's in the event app.
Yes.
The BIOS as well. So
Okay.
it's first on the.
Okay, or I'll just Google it. Don't worry. I'll look it up. Okay? Okay.
Well,
I need to introduce you. Okay, wait, I'm not doing your thing now. So, you are introducing Margaret. How are you?
Yes.
And so, tell them.
Nicholas wanted to make sure that you introduce me.
Is this okay? Great. Okay. Hello, everybody. We have an absolutely packed session, so I would like to start on time, and I also have a few housekeeping notes. So thank you very much for joining us today. Welcome to the session. This is a WHO session on viral hepatitis and HIV among people who inject drugs and people in prison settings. Before I start the introduction, I have a few housekeeping notes. Where did my housekeeping notes go? All right, excellent. Okay, here, a few housekeeping notes. We do have an injecting equipment van on site during the conference, located through the front entrance of the venue, and take a left into the car park. If you'd like to have a tour or find out information, please feel free to visit the van or see the team in the fine room. Also, join us for the Point of Care HCV Diagnostics Improve Test and Treat Pathways Symposium tomorrow morning at 8 a.m. in the Le Monde Auditorium. And finally, there are still tickets available for the conference dinner on Thursday, so please see the help desk to purchase one if you haven't purchased yours already. Okay. So without further delay, I'm really pleased to be chairing this session alongside with my colleague here. I'm Natasha Martin. I'm a professor in the Division of Infectious Diseases and Global Public Health at UC San Diego. I'm very pleased to be co-chairing this session with Dr. Philip Brugman, who's the head of internal medicine at the Arad Center for Addiction Medicine in Zurich. He's also a research fellow at the Institute for Family Medicine at the University of Zurich, and he's the co-founder of INHSU. So welcome, and nice to see you again, Philip. So the aim of this session today is to showcase and disseminate the latest WHO guidance around drug user health and infectious disease. And it's also to reflect on viral hepatitis elimination in people who inject drugs in prison settings. This is a 90-minute session, and what the format of the session will be that we will start with an introduction by Nicholas at the WHO. That will be followed by several speakers, and then the session will conclude with a panel discussion. So, without further ado, I'm very pleased to introduce Dr. Nicholas Luhmann. Nicholas is a medical doctor with a Master of Science in Public Health at the University of Berlin. He's been working for more than 10 years on access to healthcare related to HIV and viral hepatitis prevention, testing, and treatment, and he joined the WHO headquarters in Geneva in 2019. Welcome, Nicholas.
Thanks, Natasha, and thanks for both the chairs having accepted to chair. It's quite nice to see that so many people are still coming to a session. It's getting a little bit late, so I hope you're still able to concentrate on some of the very interesting content that we will be looking at. I think I'm going to try just to really give a short background presentation showing some of the most recent strategy targets, guidance from WHO, but the meat of the session for me is really with the country presentations and the other speakers and then the panel discussion. So it's a bit theoretical because I'm just going to present quite quickly some of the core new WHO guidance and documents. This focuses on low and middle income countries as per our mandate. Okay, so the new global strategy and targets. So the first thing I wanted to highlight, I think we possibly all know here, but is that from our latest 2021 progress report, the burden of hepatitis B and hepatitis C in general remains really very, very large. And I mean, you know all the figures for PWID and maybe as well for prisons, so I didn't put them up again, but we have almost 300 people living with chronic hepatitis B and around now estimated 58 million with hepatitis C, with maybe a small decline, notably due to around 10 million people treated now since 2015. And we see almost or around 3 million new infections per year for both of those types of viral hepatitis. Very interesting finding as well from this report is what you see in the red for the global and then the breakdown by region. So on the left is hepatitis B and on the right hepatitis C. This is the testing or diagnosis and treatment coverage, and you can see, for example, for hepatitis B on the left, 10% only know their status and 2% only are treated. A little bit better for hepatitis C, but the gaps are enormous. If we would put HIV against it, it would look very, very different. So for hepatitis C, only around 20% know that they live with chronic hepatitis C and 13% have been treated. It is progress, but huge gaps. So in this framework, this May, a new global health sector strategy until 2030 has been discussed and noted with appreciation by the member states at the World Health Assembly in Geneva. And it's a bit of a busy slide. I just wanted to highlight really what is new in this one is that it is much more integrated. It has HIV, viral hepatitis, and sexually transmitted infections in one strategy, and it highlights much more than before person-centered care and as well a good focus on equity in health, and it is highlighting very much the importance of, for example, person-centered care in prison settings, in key population settings, in harm reduction settings. So now I'm coming to the targets. Here, I don't want you to look exactly at the targets, but reflecting the integration, I just wanted to very quickly show that for incidence and mortality, we now have new overall targets. It means, for example, we say that the number of new HIV and viral hepatitis cases per year should be below 500,000 in 2030, and similar for mortality, for example, from cancer. For hepatitis B and C, we've gone from what was initially more relative targets, a reduction from 90% and 65% in incidence and mortality, now to absolute targets. So in red, it was just the examples for hepatitis C. So we see an overall target for the reduction in hepatitis C cases down to 350,000 new cases in 2030. That would be 5 per 100,000. I actually forgot, I should have highlighted just below that, below the first red square, that there's a specific target as well for people who inject drugs, which is very important to us and our work. So that gives us guidance. What are we expecting as a final target based on baseline modeling, actually from Peter Wickerman's group? What do we expect as a 2030 target in terms of incidence rate in this population, and then similar a target for hepatitis C for the mortality as an absolute target, and then same type of targets for hepatitis B. Then there are the program targets. So again, just as an example, same exists for hepatitis B. If we focus on hepatitis C, we have diagnosis and treatment targets with a midpoint 2050 and then 2030 for hepatitis C diagnosis and treatment. And then we have the prevention targets for harm reduction that haven't changed much, and blood safety and safe injection in healthcare settings. So what WHO does in many disease areas is as well, beyond setting targets, is validating countries for the elimination, for example, or eradication. a lot of work goes into eradication validation of polio, for example, or elimination of malaria. And so we actually have set the first time, it's an interim guidance for defining the criteria, what would a country need to meet as targets to have been eliminating hepatitis C as a public health threat, or B as a public health threat, or both. And in red you can see the impact targets that are aligned with the targets that I've just shown and have a specific target for people who inject drugs, and the program targets that both need to be met to be validated. And we will actually, I hope, hear from Egypt, for example. We've piloted in 6-7 countries, including the UK, including Egypt, including Georgia. And what we learned from those pilots is, first of all, many of those countries made enormous progress. Secondly, some of those data points are difficult to measure. There are examples for all of them from the different countries, but no country has been really able to assess all of those targets perfectly well in terms of measuring incidence in different populations can be quite difficult, and even some of the coverage targets are quite hard to assess. But we now have this, we will finalize this guidance with the learning from the piloting and have a final guidance, and we hope that we can move towards validating the first countries for elimination of hepatitis C as a public health threat in the next few years. So in terms of guidance, a couple of updates, and now all of a sudden I'm showing HIV figures, but I wanted to as well show those figures that are new, that come out for the AIDS conference in July. And as we're obviously speaking person-centered care, I thought it was interesting to just say, you know, how important it is to have key population guidelines, and that you can see on the left the global estimated new infection breakdown, and showing 70% of new HIV infections are in key populations. And if you take the African region out, you can see that, for example, 18% of new HIV infections are with people who inject drugs. So in this framework, we have developed the new key population guidelines, many in the room involved as well, as for some of the other products. And they are now across HIV, viral hepatitis, and STIs. And so one of the biggest changes is that they are person-centered now. Before there have been HIV guidance, now there are really guidance across those 3 disease areas, a little bit reflecting our strategy and reflecting that need for more integrated care. This hasn't really changed much, but is more highlighted than ever before in that guidelines, we at least hope, is that the enabling interventions are very, very important, and they are recommended by WHO. We heard today in the plenary that we should all think and talk about decriminalization, or at least changing punitive laws and policies, reducing stigma and discrimination, work always together, empower community, and address violence. And it has been recommended, I believe, since 2016 or 2017, and still very much highlighted in our guidance. Then there are the service delivery chapters, or the person-centered care packages through prevention, diagnosis, and treatment. And I'm not going to go through them, but you can find here the different packages and services for HIV, hepatitis, and STIs. And then new as well, and some have really appreciated that effort, we're highlighting broader health interventions that are not directly contributing to having an impact on HIV, hepatitis, or STIs, but they're very important for more person-focused care. And so you can see, obviously, different, depending on which group population we talk, maybe some difference in the importance, but we mental health, a lot of reproductive health services, TB, and other very important areas that we think are very crucial in providing to those populations. This gives us, as an example, for people who inject drugs, a service package that looks like that. In green, the enabling interventions, then the essential communicable disease interventions in this kind of pink, and in the darker, I don't know what that color would be in English, at the bottom, the additional health broader health interventions. There are as well a couple of new recommendations that I just wanted to highlight. I can't go into detail with those. And the first one is actually Margaret Heller's group, who's done the systematic reviews for the next 2 recommendations. There are 2 new recommendations that are specific to hepatitis C. And the first one is that we thought that in view of the really vision of elimination, and as well in view of a continuous care, we wanted to see if we can recommend retesting people, for example, after cure or after spontaneous clearance. And we've heard yesterday that this is done in prison in Spain. We heard this morning that it is done, I believe, in the INHSU films that we saw in Australia and Scotland, if I'm not mistaken. So really recommending that people at ongoing risk, people from key populations, and the history of treatment-induced or spontaneous clearance are offered 3 to 6 monthly retesting or testing for presence of viremia. And then there are a couple of remarks that you can find in the guidelines. And a little bit, and I think maybe Margaret will comment on that, and a little bit in the same vein, we recommend as well now that people are offered without delay for recently acquired infection DAA-based hepatitis C treatment, meaning that in a discussion with the patient to consider that people do not for recent infection, when we know that it's a recent infection, wait for potential spontaneous clearance, but they're really offered immediate treatment. That's the specific hepatitis C recommendations. And then there is, from other guidelines, it doesn't matter for you where it comes from, but what I pulled together are other new recommendations that are very recent in terms of service delivery now. So one is that we now formally recommend decentralization, integration, and task sharing. We've heard as well a lot of examples this morning, and it will go on for the whole week, I believe. It hasn't been a formal, evidence-based and graded, as we call it, recommendation by WHO. So these very important recommendations for service delivery are now formal and include, notably, these facilities may include primary care, harm reduction sites, prison, HIV clinics, as well as community-based organizations and outreach services. So this is clearly spelled out, for example, in the decentralization intervention. What is interesting, I can't go through the evidence, but the systematic review, and that I think is really something which I find quite interesting. This is a decentralization integration recommendation for all populations, but the huge body of evidence has come from all the work that you do since many, many years. The body of evidence for this, where it was the strongest and for most studies came from, was from settings such as people who inject drugs type settings, harm reduction settings, OAT clinics. So the evidence that then was expanded to a larger recommendation really from the work of this community. And then there are as well more diagnostic specific recommendations around using point of care for the diagnosis, for test of cure, and another one for using reflex testing. Maybe just last one, it has been as well, we now have a formal, 2 last ones, formal recommendation for using peer or working with peer navigators. I think that's been done for many, many years, but as well formalized here to support people from key populations to start HIV, viral hepatitis, and STI treatment and to remain in care. So really something where we pulled all the evidence together and looked at how strong it was and if we can recommend that not only in a narrative form, but as a formal WHO recommendation to all of our member states. And in a similar way, we now recommend online services as an additional way to offering services, respecting data security and confidentiality, which the GDG, the guidelines group, found a very important addition to this one. Sorry. And the last one I wanted to mention, we have since more than 1 year now a self-testing recommendation, and there's a lot of Unitate-supported implementation research, and FIND is doing a lot of research in this area showing really increased uptake through self-testing in different settings and populations, and so I think that will be expanded as well in the years to come. My final slide is this, and I have 30 seconds left. It is really to show that the Global Fund, aligning with some of the WHO work, has now really made 2-3 major changes. One is that harm reduction and human rights in the new proposals that will come up are now program essentials, and the countries really have to justify if they don't include them strongly. Proposals can now include hepatitis B vaccination, testing and treatment, and hepatitis C testing and treatment, regardless of HIV status. That is new in their proposals. There is an opening for non-injecting amphetamine drug use, and all those points apply as well for prison settings. Sorry. These are my acknowledgements. And I thank you. I lost my voice at the right moment, I believe. Thanks.
Thank you so much, Nicholas. That was excellent overview. We actually do not have time for questions just at the moment, but feel free to ask questions in the later session or after this session.
Okay, so we immediately start with the first session, present with two case studies, 8-minute case studies. The first one is coming from Professor Margaret Hellard. She's a Deputy Director at the Burnet Institute in Melbourne, Australia. Margaret's work focuses on preventing and improving the management of blood-borne viruses. Elimination is the ultimate aim. Margaret is a member of numerous advisory committees, including co-chairing the WHO stack on blood-borne viruses and sexual transmitted infections. And her case study is on experiences with HCV retesting and immediate treatment in harm reduction programs in Australia. Please, Margaret, thank you.
Thanks so much, Philip, and thank you for the invitation to speak. And I'm going to really romp through this, and you're mostly going to see pictures. And if you would like me to, if you want any detail of the studies I show you, just come up afterwards, because I figure in 8 minutes there won't be time. Just my disclosures, I do receive investigator-initiated grants from Gilead, AbbVie and Merck in the past, and also this work is done by many, many people. So Australia is aiming to eliminate hepatitis C as a public health threat by 2030. It's in our national strategies that's what we're trying to do, and it lines up with WHO and across also our different states as well. And the way we're trying to measure it is we actually have an annual report that comes out every year, which is trying to assess our progress towards elimination. I'm happy to give you more details on this. But to put it in summary, we're probably about 50% of the way there, which is good and bad, and I'll explain why in a moment, but at least it's better to be 50% of the way there than not having started. We are seeing a reduction in hepatitis C incidence. We can measure this, and this comes out of that report, and the new report will be released for this past year in the next couple of weeks. So this is data from last year, but we've got a falling in incidence of hepatitis C, both within clinics that see high caseloads of people who inject drugs, as well as in our high caseloads of gay and bisexual men from our access surveillance system. Prevalence is also falling, and other work, there's lots of other work that shows this as well from the needle and syringe program, Lisa Meyer and team and the like. But critically, what we've had is a massive fall off in the numbers of people taking up treatment. And this remains a problem, and it's sort of stabilising, but essentially we're not treating enough people at the rate we're going, in my view, to reach those elimination targets. And partly what we're doing is we're not testing enough people. So I'm going to sort of just say that as sort of the beginning place, that essentially we're not treating enough, and partly we're not treating enough because we're not testing enough, and if you're not testing enough, it means you're not engaging enough, so you need to be really rethinking your strategies a little bit. I'm going to talk about some givens. Basically, reducing hepatitis C incidence. If the majority of your infections predominantly occur in people who inject drugs, then most of your testing and treatment needs to occur there. That's Australia's epidemic, and you need to change what you're doing depending on your local epidemic, but that's critically important. Majority of people who inject drugs want hep C treatment and achieve good outcomes. I think most of people in this audience know that, but you'd be surprised that others don't. Community-based treatments, outcomes are as good, if not better, than tertiary hospital settings. Yet despite this, around the world, that's not the case. Again, I'm not going to go into details. If you want evidence, if you want the details of that, I'm happy to speak to you afterwards. Community-based treatment is also highly cost-effective. We've done lots of models on this. Other people have done models on this. So how do we then make this happen? And to me, it's about understanding where you're up to in your elimination efforts, and to say maybe for the first lot, you've done your willing, waiting and warehoused, and motivated. And now in Australia, I think we're at the hesitant, need social encouragement, doubtful, uncertain and unaware. And how do we then engage with those people? And to me, part of it is not expecting them to come to us, but we need to think about how we go to them. So aim for a one-stop shop. Consider where to locate the shop in the community. Is it at a clinic, a needle and syringe program, supervised injecting facility, a prison, pharmacies, a van, a drug and alcohol service, a mental health service? I actually don't care where your shop is. I just think you need to get your shop out there and in lots of different ways. And the shop should be obviously welcoming of the clients you want to see. We need to reduce visits and we need to simplify testing and monitoring, so get rid of most stuff. EC Australia, which has been a big study that has been run by a partnership with the Burnett Institute, but virtually every place in Australia has been trying to catalyse the response and try to look at, in all different methods, how we might do this. How do we increase community? So testing all sorts of different methods and then evaluating them and then basically costing them and saying what's the most cost effective. So there were over 20 of these projects were funded in the last couple of years, trying to understand in community settings what's the best way to do this, the most effective way to do this and the most cost effective. And we're just getting those results through. Telehealth, you don't actually have to see people all the time. In a country like Australia where it's vast, maybe you just don't have to. Maybe telehealth will work, but not always. Prisons work as a place to treat people for hepatitis C. It's ridiculous that we continue to incarcerate people as we do, but we do in Australia, but they're a very effective place to treat people. So if we're at least going to do one good thing about incarcerating, this is work from Alex Thompson and team, but really highly effective. And also pharmacies work, so work which we did with John Dillon and others has clearly shown that pharmacy-based therapies can be really, really effective in reaching populations, and I think this needs to be rolled out and we're looking to roll it out in Australia further. Safe injecting facilities, so Nico Clark would have maybe talked on this, but work. So again, where people who inject drugs are environments where it can work. Jason Grebley is leading work on a national scale-up of point-of-care testing, and we're looking at different ways to do this. Again, we need to really looking closely to see does it work in all settings, what's the cost and all of those, but really point-of-care testing if possible. The Quick Start study, which is a study that I'm a lead investigator on, is really asking the question of, and to me the critical arm for this, which I think has relevance globally, is do you actually have to do an RNA test, or can we get away with doing an antibody test first? The person then gets, if they're antibody positive, gets given their pills and gets the follow-up test sometime later, like they might get to confirm that they're RNA positive. And similarly, we'll be doing some work, hopefully in the coming period with Medicine de Mont and others, really again looking at this, can we get away with just having an antibody test that's really cheap? So these are new innovative approaches that I think we have to start to do and say, what can we do that makes it cheap and simple for the punter when they come in? As well, we're looking at VenC. So we're basically putting into the machines that give out clean needles and syringes, we're putting in testing packs for hepatitis C tests. So this was a pilot study which was effective in terms of them being picked up. We had great difficulty evaluating it because the punters wouldn't contact us to answer their survey, so we have to think about how to do that. But they actually took all of the tests, so it was effective except hard to evaluate in the sense of what happened. No more C, so not just prisons, but large numbers of people in Australia who are engaged in the correctional settings or the justice system actually are in community corrections. And can we basically take our vans to where the parole officers are? How do we actually get this group of people to test and treat? So we're about to start a pilot piece of work to sort of basically assess the feasibility of how do you work with the justice system outside of prisons as well as inside of prisons, using point-of-care tests and simplified approaches. Point-of-care testing as well in the PIVOT study, where it's again saying, well, when people are coming into reception, can you use point-of-care tests? So I've gone really, really fast, and I'm not going to explain any of those tests in details because I was given 8 minutes, and I wanted to show that, in fact, I think critically, it is not one model of care that is going to do the job here. It's multiple different models of care in community settings where your community is that serves that community rather than going, oh, it has to look like this, this or this. But what I do know as a person that works in a tertiary hospital and is a specialist is it's not the tertiary hospital, because you don't know who's not coming to sit in front of you. You'll never know who you're not treating. So in summary, we've made really big progress, but we have to do a lot. We've got a lot further to go. And we need to basically take care to the community where people are. We need to remove barriers to care, less tests, less visits. We mustn't compromise on the quality of the service. We must simplify, simplify, simplify. Lots of people to acknowledge, stacks of people in fact. This is the partnership that we have across the country for ECA. This is not a job that any one person, one group, one government does alone. It's a whole bunch of people have to work together, and you have to get the news out to the punters. Thank you.
Thank you very much, Margaret, for this very comprehensive overview. It's, I think, very impressive for what you are doing in Australia. There is time for a question if there are any questions in the audience. Otherwise, we continue. Our next speaker is presenting virtually. It's Svitlana Leontieva. Svitlana has worked at a PATH in Ukraine as a chief of party of USAID Serving Life project aimed at decreasing transmission of HIV, tuberculosis and hepatitis C among people in conflict with law. Svitlana has 20 years of progressive experience in technical leadership for international donor projects in Ukraine, and she will present on scaling up prisoners' access to integrated HIV, HCV and OAT services in Ukraine. I hope it works with the video conferencing.
Can you see my slides?
Yeah, we can see it.
Yeah, great.
Thank you.
Thank you so much for this opportunity. My name is Svitlana Leontieva. I'm the chief of party of the PATH-led USAID Serving Life project. And today I'm honored to present how the Serving Life integrated and scaled up prisoners' access to the comprehensive, person-centered, integrated HIV, hepatitis C virus, and opioid agonist therapy services among prisoners in conflict with the law in Ukraine. I have no conflict of interest to report. First of all, I would like to highlight that before 2018, there was no access to comprehensive integrated healthcare services. No diagnostics on HIV, tuberculosis, and hepatitis C using GeneXpert diagnostic platform was available. There was no HCV diagnostics and treatment in Ukrainian prisons, no index case testing, no opioid agonist therapy, and moreover, no penal staff was trained on delivering integrated comprehensive healthcare services. Through the USAID 5-year PATH-led Serving Life project, PATH focused on expanding access to integrated healthcare services, including HIV, TB, HCV, at penal settings across 12 project regions of Ukraine. In 2018, the project developed and obtained approval from the Minister of Justice on a set of standard operating procedures for Serving Life's comprehensive integrated healthcare service package. At this slide, you can see the topics of each of the standard operating procedures approved by the Minister of Justice Center of Healthcare. Also in 2018, Serving Life developed and introduced an integrated HIV, TB, HCV screening questionnaire for use in both penal and probation settings across 12 PAPFAR-supported regions of Ukraine. And within 12 months, in 2019, more than 33,000 prisoners were screened for HIV, TB, and HCV, showing the following results. 79% of those prisoners screened showed HIV risks, and 58% showed HCV risks. In a year, in October 2019, Serving Life institutionalized HIV, TB, HCV screening using a Ministry of Justice approved screening questionnaire in 100% of all penal and population and penal and prison settings. Also within our project, we piloted, we accelerated diagnosis for HIV viral load and HCV viral load and TB and rifampin resistance in one of the selected penal setting, Dnipro Penal Institution number 4, where we procured and placed a GeneXpert machine. 242 detainees living with HIV received diagnostic services using GeneXpert, and 133 detainees provided with simultaneous HCV/HIV viral load testing. 15 individuals were offered with full suite of HIV, TB, HCV diagnostic testing. 2 were diagnosed with HIV, TB, and HCV. I would like to highlight that using of GeneXpert platform to accelerate integrated and timely diagnostic of HIV, TB, and HCV proved to be efficient and client-centered approach within the Serving Life project, and it was scaled up by the Ministry of Justice to 100% of penal settings in Ukraine. Also, we piloted a model offering the full suite of HCV screening, diagnosis, and treatment for penal populations within 12-month pilot in Khersonska Oblast of Ukraine. More than 1,700 prisoners were enrolled in the pilot program and tested for HCV following screening. 41% of prisoners screening at risk for HCV were diagnosed with HCV. Also, this pilot showed very high HIV-HCV co-infection rate, 81%. And the pilot also showed high HCV treatment efficacy, 93%. The figure at this slide shows the cascade of HCV services provided during this pilot. Also, our Serving Life project implemented, I would say, an unprecedented scale of advocacy activities, advocating for sustainable financing on expanded HCV diagnostic and treatment services in prisons. In 2019, following our advocacy campaign, MOJ procured for the first ever time in Ukraine 60,000 HCV rapid tests and drugs to treat 495 prisoners with HCV using the state budget. Already in 2020, Ministry of Justice outsourced to a private laboratory to provide HCV diagnostic services to more than 3,000 prisoners, again with funding from the state budget. In 2021, MOJ procured again for the first time HCV direct-acting antiviral treatment courses for 2,600 prisoners. And we would say that from 2021 onward, timely diagnostic and viral load monitoring services for HIV, HCV, and TB were available in Ukrainian penal settings. The figure, you can see the results from our HCV rapid testing in Ukrainian prisons. Almost 42,000 prisoners were tested for HCV, 36% were confirmed with HCV. Also, Serving Life integrated opioid agonist therapy into the integrated healthcare package at Ukrainian prisons. We developed SOPs to guide OET program, created a medical advisory board, multidisciplinary care team to manage services for our OET clients. We established and equipped OAT rooms at the pilot sites with required commodities in partnership with other international and national partner organizations. And we also linked OAT clients to civil sector OAT programs upon release. And you see that if in 2019, OET was launched in one prison, it was just the launch of OET program, and 6 first prisoners were clients of OET. Already in 2022, we had expanded OAT to 4 sites, and 187 clients were on OAT before the Russian-Ukrainian war. Our project institutionalized the integrated HIV, HCV, and OET services in Ukrainian prisons. Starting October last year, provider-initiated testing and counseling was provided only by penal healthcare workers without any donor support. Ministry of Justice approved or finally 13 SOPs on integrated HIV, HCV, and OET service delivery for use at all penal settings in Ukraine. More than 1,100 penal and partner organization staff was trained on integrated HIV, HCV, and OET services delivery. I would like to acknowledge on behalf of PAS, the Ministry of Justice of Ukraine, its Center of Healthcare, its Center of Probation for demonstrating a political will to introduce, to scale up the integrated HIV, HCV, and OET services for people in prisons, as well as I would like to thank our donor, United States Agency for International Development, PEPFAR, Global Fund and Serving Life Project Implementation Group, and our 13 national and regional partner NGOs who partnered with us and contributed to the implementation of the integrated HIV, HCV, and OET services for people in conflict with the law. Thank you very much for your attention.
Thank you very much, Svetlana, for this nice presentation. Are there questions?
Just to point out, there's a microphone in the middle of the room on the side. If you do have a question, please make your way over.
So no questions at this moment. I propose that we continue with the second part of the session, and I hand over to Natasha.
Okay, wonderful. Thanks so much. So the second part of the session, we'll talk more about models of care and implementation. And we have two virtual speakers today. Thank you very much for joining us. I realize under difficult conditions with different time zones and everything. So thank you very much for joining us today. The first speaker that I would like to introduce is Dr. David Beliashvili. Dr. Beliashvili is a medical doctor who received his degree from Tbilisi State Medical University and a PhD from Emory University. He participated in the preparation and launch of the Georgian Hepatitis C elimination program and is currently the scientific lead for viral hepatitis activities at the CDC in Georgia. Today he'll be talking about hepatitis C incidence, WHO elimination targets, and the case of Georgia. Welcome, Dr. Beliashvili.
Thank you very much for a nice introduction. I hope everyone can hear me well. So I will briefly discuss the HCV incidence targets set by WHO and review the case of Georgia. Nicholas briefly, not briefly, but in more details already touched this interim guidance for country validation, but also wanted to mention here that HCV incidence indicators with some measurement options were provided in the interim guidance for country validation. There are two incidence-specific indicators that countries need to achieve for validating the hepatitis C elimination. This is incidence in general population with the target of 5 or less cases per 100,000, and incidence among people who inject drugs with the target of 2 or less cases per 100. For the context, a brief overview of the hepatitis C burden in Georgia. We had the baseline prevalence estimate from 2015, which showed that 5.4% of adult general population had chronic hepatitis C. After that, there was nationwide hepatitis C elimination program launched with tens of thousands of people treated, and then repeated survey in 2021 showed that the prevalence declined to almost declined almost threefold to 1.8%. This suggests that Georgia gets closer to its elimination targets, and measuring these elimination validation indicators is becoming more and more important. So there are multiple methods suggested for monitoring hepatitis C incidence, including some of these methods highlighted from the WHO's sources and interim guidance. Kind of gold standard is prospective HCV retesting of people at risk, but this requires large sample size and long follow-up. And even though this is a gold standard, it's not feasible to be conducted in every country and in high frequency. So there are several other alternative options. I will not go to each of them separately, but want to highlight a few which are more feasible for Georgian context. We are already working on a project with retrospectively collected HCV retesting data. So this is using programmatic data and finding people who are tested twice or more. There are also some laboratory methods, such as HCV avidity assay, that can be used to identify more recent infections. And we are currently in conversation with several groups and assessing the feasibility of this kind of study in Georgia. Also, relative HCV incidence trends can be obtained from surveillance of acute HCV infection. And this is also feasible in Georgia because we recently established the Sentinel surveillance for acute HCV. And we hope that after it's fully launched, we will be able to monitor the number of new cases, at least in Sentinel sites, over the next few years. And one more alternative approach suggested by the WHO is to use trends in reduction in HCV viremic prevalence over time as a proxy measure for incidence reduction. And as I mentioned, we already have 2 nationwide serosurveys, so we have good baseline for using this method. And we are also working on several projects to supplement this data with additional data, for example, from the prevalence in hospitalized patients who are routinely screened in Georgia. So now, briefly about already completed studies and evidence existing on hepatitis C incidence. First one, I wanted to mention the prospective cohort study, which assessed HCV seroconversion among anti-HCV negative people who inject drugs, and it found that incidence of 0.77 per 100 person year, which is quite low and below the target by WHO. In addition to that, there were 2 prospective cohort studies looking at not HCV negative, but people who were already treated for hepatitis C and achieved SVR. So this first reinfection study was done in 2015-2017 and found the incidence rate of 1.2 per 100 person year. And another similar reinfection study, more recent, had larger sample size of over 800 people and found incidence of 2.67 per 100 person year. Another existing evidence that we have about incidence is from modeling, with huge help from our great collaborators from Bristol University, Dr. Peter Wickerman and his team. There is models developed specifically for Georgia, which with the most recent estimate comes from March this year, and it estimated that incidence in total population is about 66 per 100,000 person year, and the incidence among PWID is 1.14 per 100 person year. Both of these suggest approximately 60% reduction since 2015. And then lastly, about the project that I briefly mentioned before, we use seroconversion cases from the National HCV Screening Registry to estimate the annual incidence. This includes just adults who have 2 or more tests done during 2017-2021. Overall, we have more than 900,000 people with two anti-HCV testing. And briefly about results, I know I'm running out of time. We found 13,000 seroconversions among these 900,000, suggesting a seroconversion rate of approximately 1.4% individuals. And antibody seroconversion was more common in males versus females and in older age groups, as you can see on the figure. So to summarize, the existing evidence from Georgia suggests that the country might have already reached the target set by WHO for hepatitis C incidence among PWID already reached or is very close to reaching it. But the estimated incidence from modeling and number of seroconversions observed suggests that incidence in general population is still much higher than the target set by the WHO. Therefore, preventive measures should be maintained and further scaled up for both PWID and harm reduction activities to maintain this progress, and in general population, mostly our concerns are about infection prevention and control, which need to be strengthened to continue the successful trend of declining incidence. And we also found that the programmatic data provides unique opportunity to identify the new cases, but there are further analytical steps still needed before we can extrapolate these seroconversion cases into estimating the overall incidence in total population. I know I don't have time left for going over each of the collaborators and my colleagues who helped in this project, but this is a huge collaborative efforts currently undergoing in Georgia, so I would like to thank them all. Thank you, and I'll be happy to take any questions either now or the question has the time allocated for that. Thank you.
Thank you so much for joining us today. Are there any questions from the audience? I have a quick question while the questions are brewing. Is there surveillance or monitoring? I think it's fascinating you were describing the different ways that you're trying to triangulate different pieces of evidence towards hepatitis C elimination and incidence reductions. Are you doing monitoring in prisons settings? And if so, can you talk a little bit about that?
Yes, thanks for the question. Yes, the prison setting was one of the first actually to implement the treatment program and treatment program. However, the screening system is not directly integrated into the overall nationwide HCV screening registry. However, there is one other project currently underway, which will aim to link the prison data to the programmatic data and to see the testing trends in prison setting.
Great, thank you very much. Any other additional questions?
I have a question about the incidence issue in the general population. What do you think are the reasons that you have still quite a high incidence in the general population?
Well, we are trying really hard right now to figure out what are the main drivers. There was like quite an extensive blood safety monitoring and scale up of prevention. We knew from 2015 survey that blood transfusion was one of the prominent risk factor that the data showed, but the blood safety program has improved dramatically since then, and the data suggests that its blood transfusion as a risk factor has substantially decreased. So that leaves us with the suspicion that it's mostly other healthcare-related transmission related to infection prevention and control measures being inadequate in the healthcare settings. but also non-healthcare settings also, but we don't have any good data about that, for example, in tattoo salons.
Thank you so much. Thank you so much for that very interesting presentation. We'll need to move on to our next speaker, so thanks again. And I'm pleased to introduce our next speaker, who is Professor Mohammed Hassani. Dr. Hassani is the Health Minister Assistant for Projects and Public Health Initiatives in the Ministry of Health and Population in Egypt, and he's the Director of the Hepatitis Elimination Program. Today, he'll be talking about improving health services for drug users in the framework of hepatitis C elimination in Egypt. Welcome.
Thank you very much, Chair, and it's an excellent opportunity to share in this distinguished event to put some highlights on the Egyptian efforts in improving the patient-centered services in one of the most important members of the key population group, which are the IV drug users. And this is my disclosure. And starting nearly 8 years back, and in particular in 2014, Egypt conducted the first population size estimate on a national level and revealed that the estimated number of people who inject drugs in Egypt at that time was approximately 93,000, representing almost 0.36% in the age group from 18 to 59 among males. And now we are preparing to conduct the second survey by early next month, and also it will be linked to an integrated biological and behavioral surveillance survey. And hopefully we expect the results to be available by early April 2023, and we are counting on the importance of this update to guide our national efforts in this regards. And bearing in mind the importance of such a group and the national efforts to provide them with a comprehensive health package to support their health and well-being, and also to be aligned with the national efforts towards hepatitis C elimination in Egypt, which Egypt taken a big step towards, which transferred Egypt from the country of the highest burden of hepatitis C worldwide, reached to in 2015 to 70% of its population infected with hepatitis C, to the nearest country to hepatitis C elimination in the near future, with the efforts of the massive screening campaign, which was conducted in 2018 and 2019. And also there is a wide range of services provided to the IV drug users, started from the prevention until a proper linkage to care, in which I will elaborate more in the few coming slides. When it comes to awareness as one of the essential pillars, a multi-sectoral integrated governmental plans of awareness, including the direct communication channels such as through the hotline and the mental chatbot, or even indirectly through intensified media campaigns using many beloved celebrities, or through the social media interactions, or even the awareness materials which are available on a dedicated website for all the targeted population. And as a part of the mega efforts in the screening of viral hepatitis, especially for hepatitis C and HIV, a remarkable expansion of the testing services has happened during the past 3 years, allowing for easy access for the people who inject drugs to be frequently tested, either through fixed screening points at the mental and addiction hospitals, or through the HIV clinics, or through the multiple VCT centers, either operated by the government in the prisons, or by the civil society organizations, which are additionally leading the efforts of the outreach programs. Through combined public and UNODC efforts, the hepatitis B vaccine is available at all the public centers for immunization of people who inject drugs and their families. And also one important milestone was achieved through the easing the access to care through timely linking of the discovered cases with hepatitis C, hepatitis B, and also HIV to receive their further evaluation and proper treatment through an extensive network of treatment centers located inside the addiction hospitals without the need to go to any other specialized hospitals. And also all these centers are well equipped with the point of care testing and all the available or the needed medications. In 2015, we started the needle and syringe program through the activities of small-scale scattered NGOs in 2 Egyptian governorates, with no clear or measured objectives or outcomes. But in 2020, we had a remarkable progress happen through the first public NGO official collaboration with 2 prominent civil societies have a long experience and capacities in HIV and its related programs. Through that collaboration, the Ministry of Health provides syringes to the NGOs to be distributed through the outreach programs, and all these activities are closely followed and monitored by the Ministry of Health. And in 2021, the program scaled to cover 8 Egyptian governorates through 11 NGOs, and Ministry of Health plan to include more NGOs in the program during 2022 and 2023 with wider geographical distribution. And so far, we have reached the level of distribution of 270 syringes per person who inject drugs per year, and hopefully to meet the WHO target, which is 300 syringes per person year by the first or second Q of 2023. And one of the benefits of COVID-19 was to launch the virtual clinic, which helped to offer consultations and follow-up during the past period through an open, free, bilingual, secured virtual platform moderated by a specialized group of consultants in mental and addiction services who succeeded to hold more than 3,000 sessions in the first year of launching of these virtual clinics. And this make a lot of easiness for many of the IV drug users and target populations to access many of their specialized physicians, to ask them frequently and also to interact with them about their updates and their health-related problems. And now we are witnessing the crowning of the harm reduction efforts in Egypt through the introduction of the opioid substitution therapy program for the first time. And after nearly 2.5 years of preparation of the regulations and putting all the regulatory authorities guidelines in mind, and also preparing the guidelines, training with many of the supporting agencies like UNODC and Manara, and also capacity building for the teams that will work on the opioid substitution therapy program, and finally the procurement of the target drugs, which will be the methadone, buprenorphine, and naloxone, expected to reach within the few coming weeks. Our plan in 2023 is to include 8 hospitals to accommodate nearly 1,200 patients by the end of the next year through a stable process that allows for proper monitoring and evaluation. And it's worth mentioning that Egypt is financing all the program's pillars through its domestic budget, supported by a robust political will. This is my final slide, and now we started to see all the national efforts on the rate of infection, which began to decline and reached 7% HCV positivity among people who inject drugs in 2021, instead of almost 50% positivity rate in 2017. And we are working intensely to achieve the WHO elimination targets in the people who inject drugs to match the achieved targets in the rest of pillars, inshallah, by the mid-2023. Thank you very much.
Thank you. Thank you very much. I think we have time for just 1 or maybe 2 questions. So I have a question about the virtual consultations you mentioned, and whether you think that that's going to be a key feature of sort of expansion of these services going on in the future, or will that just be something that was sort of temporary for COVID?
One of the great benefits that we actually gained through the pandemic of COVID-19 is to settle this clinic and to have the sensitivity of its moderation and operation, and also the continuity of its services. Unfortunately, we still have a good engagement from the people, either from the people who have suffered from any mental problems, or even those who have the people who inject drugs. And we have now improving the access to service through easing of the, the methods to log in and to keep this service freely, always to keep the momentum of engagement and the number of people who are engaged in this platform to be the same all through the time.
Thanks. Nicholas?
Yeah, thanks. Thank you very much, Dr. Hassanis. Nicholas Luhmann from WHO. Thanks for joining and for focusing on this very important topic of people who inject drugs and harm reduction. I don't know if you were on already, but I showed as well all the validation criteria, and you have been one of the piloting countries. And as Egypt has literally had the biggest hepatitis C elimination program in the world, I just wanted you to comment as well on the targets and progress that we have seen in the general overall population in Egypt in terms of incidence and mortality reduction, because those are just as well very remarkable, and I think would be nice to share as well with the group very quickly. Thanks.
And thank you very much, Dr. Nicholas, for the questions, and allow me to highlight some of the achievements based on the global health sector strategy targets and the targets put by the WHO for the countries seeking for validation for elimination of hepatitis. And as we may know that Egypt was one of the countries with the highest prevalence of hepatitis C. As I just mentioned, Egypt in 2015, through the demographic health survey, had a rate of infection or positive cases for hepatitis C reached to 70% of its population, which was at that time nearly 90 million. And now, after conducting the mass screening campaign in 2018 and 2019, we discovered almost or more than 90% of the chronic HCV undiagnosed cases, and we linked more than 90% of those who are eligible for treatment to be treated using direct-acting antiviral drugs. And in 2019 and 2020, we conducted the first survey post the campaign to assess the incidence reduction of hepatitis C. Unfortunately, we discovered the incidence reduction achieved at that time in 2019 to exceed 90% reduction as per the WHO required targets. And now we are conducting the second household screening for hepatitis C to follow up on the progress of the incidence after 2 years from the past one, and also the different indicators for the hepatitis C elimination. For example, the mortality. We achieved now 40% mortality reduction compared in 2021 compared by 2017. This is very near to the WHO target, which is set at 65. But are we expecting by the expansion of the efforts and early detection program for hepatocellular carcinoma and the increase the service availability and the access to treatment, especially for the advanced cases of hepatocellular carcinoma, will achieve the target of mortality reduction as well as we achieve the target for the incidence reduction. And if we're talking also about the rest of indicators like the blood safety and injection safety, Egypt has a very huge efforts in ensuring that 100% of the blood bags were screened, and also to ensure that all the syringes and needles used in the healthcare settings are auto-disabled and auto-extracted needles to meet also the rest of criteria for WHO. Thank you very much.
Thank you so much. Very, very impressive examples. Thank you again. So I think we'll move on to the last section of this session, which is our panel discussion. So if I could please invite the panelists to come sit up here, and could we ask possibly to turn off the projector display, because I heard some people's or down. That would be great. Thank you.
It's my pleasure to welcome us as panelists in this discussion round about the further needs in hepatitis C elimination and the challenges and the opportunities to eliminate viral hepatitis among people in prison and people with injection drug use. And I welcome Monica Jupeja from UNODC and Julia Sheehan from HCV Trust UK, Kanudeep Kaur from FIND India, Ernst Wiese from Médecins du Monde Myanmar, Karin Timmermans from UNAID based in Switzerland, and Annie Madden from Input Australia. Thank you very much for joining this panel.
Thanks so much. There should be 2 microphones. I think if you can share, maybe turn them on and see if they're working. Okay, great. So this panel really will be talking about covering both, what will it take to achieve elimination in prison settings and among people who inject drugs, And I'd like to start with the prison question. And so, the question that we wanted to pose was, what will it take to achieve elimination in prison settings? What are the key obstacles? What are some facilitators and opportunities? And I'd like to start with Dr. Kaur, if that's okay. As project lead for prison HCV interventions at FIND, and I know you've been instrumental in shaping HIV and hepatitis C interventions in Indian prisons, could you possibly kind of give us a little bit of your perspective on this?
Hi, thank you so much for this opportunity. I would like to say that we have got best of the opportunity, as we have test and treat policy already in place in our country since 2019. But it is there for the general population. They can have access to the facilities which are available, the services which are available. But what we see is still like very few of the prison inmates, they got an opportunity to be tested, and they have very limited access to treatment, even the policies in place. So we look forward to like a lot of challenges in this, because we could feel that there is some kind of disconnect between the Department of Health and the Department of Prisons, and there need to be some kind of bridge. To bridge the gap, we need to have some kind of they need to work very closely with each other. And another kind of challenge we look forward to is because the tests which are available, the antibody point of care antibody tests that are available with us, they are not the whole blood test, they are the serum or the plasma test. So it is very difficult, because the prisons, they don't have functional laboratories to carry out the serum and plasma test. So we need whole blood testing at the prison level. And also, if we are sending the prison inmates for initiating them on treatment, all the treatment centers, they are placed in the government hospitals, and they need multiple trips to the hospital to get initiated on the treatment. So that is another challenge. So we are training the medical and paramedical staff who are present in the prisons, so that they can initiate the patients on treatment, and we don't have to send them outside, so we can reduce the number of visits they have to make to the hospitals. And thirdly, what we see is what I want to highlight here is we are looking forward to a simplified and decentralized model of care, so that we should bring all these services right at the doorstep of the prisons, so that they don't have to go out, and we can limit the number of visits the prisoners have to make to get started on the treatment. So this is what we have done. We have modeled this, we have piloted this model of care in few of the states, and the states have really liked the model, and they have plans to replicate the model in other districts which we have not covered as part of the pilot. So that's it. Thank you.
Fascinating insights. Thanks. So I'd like to go to your right, actually, to Ms. Sheehan. And Julia, I know that you have many years' experience working with people in prison and at risk of viral hepatitis. Can you speak a little bit to your experience in terms of rights and equality in the criminal justice system, and what we need to address in terms of hepatitis elimination there?
So I think that people that are affected by hepatitis C are from a very diverse background, and are generally from a marginalised community. So I guess we need to treat them with kindness, and make sure that every person that comes into prison is an opportunity of an intervention to test, and if they're positive, to treat. And if we're swift and we have short pathways to treatment, and have a wraparound care, which is what we provide at the Hep C Trust. We're a peer-led model, so we have that lived experience, and I think that it's a powerful tool. When you share a hardship with someone, a kind of magic happens and a connection happens, and we can often turn people around who may be refusing a test, and will support them through treatment. So I think if you have an opportunity to access peers, use us, because we have the time to be able to support someone through their treatment.
So can you talk a little bit more about that peer-led model? How did that, initiative arise, and what are the sort of unique, a little bit more about that program, because it is quite unique.
I think it is unique, and I think it was a model that was our previous chief exec, Charles Gore, kind of took the idea from 12-step fellowship stuff, where people share that lived experience and connect and feel supported, and that's really how it works.
Mm-hmm. I'm looking forward to hearing more about that. So I'd like to actually turn to Dr. Shapaja. As with your work in UNODC, I know you've worked on HIV prevention and treatment among prisoners, and I wonder if you could speak a little bit more about what we've learned in that space in terms of how we can apply principles to hepatitis C elimination and any particular challenges and opportunities.
Sure, thank you. Well, I think the best way to prevent the spread of HIV and hepatitis in prisons is to considerably reduce the prison population, because, with less people in prison, so, reduce the incarceration rates for minor offenses, and in the case of people who use drugs, for possession of drugs or use of drugs, then you reduce a lot the number of people who may be exposed to hepatitis or HIV. So that would be the first thing that I noticed in my work. Then, the other, so for the people that are in prison, we have the Mandela rules, and we have to make an effort and provide the same level of health care in prison that is available in the community, because people who are put in prison are not losing their right to receive proper health care and proper prevention. And then, of course, you have to have the prevention measures, access to needle and syringe programs, access to opioid agonist therapy, access to means to disinfect other tools, because it's not just through using drugs that hepatitis C or HIV is transmitted in prison. Tattooing, it's another way of transmitting these viruses. So people have to, and these practices exist in prison with all the measures that are taken, they continue. So people have to have the means to disinfect the tools to reduce the transmission. We were talking a lot about testing for hepatitis and also for HIV, but what we saw is that just testing alone actually is not sufficient, because when you test people and you give them a positive result for hepatitis or for HIV, but they are locked in prison and they don't have any way of reaching out for treatment, then it's even worse. So testing and treatment should come hand in hand and should be offered to the scale that Nicholas actually mentioned in his presentation, and this, and also for the reinfection, to have constant monitoring and provide testing not only once but regularly for people who are spending more time in prison, and then moves us to another aspect of the problem, which is the gap between the healthcare in the community and healthcare in prison, because in many countries these are separate systems, and then there is a lack of exchange of information. So even when the system is well established in the community, it's almost unexisting in prison. And there is a need for training the healthcare staff in prison to understand the importance of testing, to know how to deliver treatment for those who need it, to understand how to monitor and make sure that there are no reinfections. So, and of course, this moves to us to political support, but also to funding, because even in countries where there is enough funding to do the program in the general community, there is very little funding for prison health, and not always, and there are many others competing health problem in prison, like the spread of tuberculosis and others. So, people have to prioritize, and providing funding for HIV and hepatitis interventions in prison is equally crucial.
Thank you so much for those insights. I think we'll move on to the second question.
Yes, now turning from the prison point of view more towards people who inject drugs, I would like to start with my first question to Annie Madden from Input, and would like to ask you where you see the major facilitator to improve HIV and HIV care among people who inject drugs towards reaching the elimination goals of WHO.
HCV or HIV, did you say?
Both.
Oh, both. Okay. So major facilitators, sorry. I would... Sorry about that. Right, I need to sort of reorient. I thought I was going to be speaking about elimination in prisons. So, look, I think, in many ways, we're probably looking at some of the similar sorts of issues, because really, if we talk about elimination there among people who inject drugs, then we're talking about, and evidence-based and person-centred care, then we're talking about basic principles that Nicholas has outlined in the WHO guidelines, so access to prevention, ensuring that people do have access to evidence-based harm reduction, essential services, which currently is not available in many low and middle income countries. We're talking about prisons having poor access to sterile injecting equipment, OAT, basic essential harm reduction services, but this is true in the broader community as well for many countries and in many settings. So that's a basic starting principle that is still very much needs to be addressed in many countries and settings in terms of access to, along the broader cascade around testing and treatment, and access to testing, diagnosis and treatment. Again, we need to be, today there's been a number of speakers talking about people who inject drugs. There's been a number of speakers, including Margaret here earlier and Neve this morning, talking about issues around trust and safety. And I think these are really critical issues when we're talking about communities of people who inject drugs in relation to both HIV and hepatitis C. If people are going to be coming forward to access services and to get their needs met, it's really essential that's in an environment where they feel safe and they can trust the information in the context in which that's delivered. And that's very difficult for populations that are criminalised, heavily criminalised. So those sorts of issues, I think this is where the peer-led and peer-delivered kind of approaches become really essential in this picture, where we have to move beyond nothing about us without us being just a rhetoric, and actually how we do that in practice, and a great deal more resourcing for that sort of work, really sort of getting behind what it takes to do that work, which can be really resource intensive, and there needs to be a lot of support and capacity building for the people who do that sort of work as well. So I would say that is one of the real missing pieces, if you like, in the elimination picture, or in addressing both HIV and hepatitis C among people who inject inject drugs, is that how we really build the peer workforce and support them, acknowledge them, recognise the critical work that they do in linking people in particular to care and to services that otherwise, that may not access. As Margaret has pointed out, you can provide services, but will people come, and will they come back to you? Not unless they trust and they are safe in those services. So that's some of the things I think about.
Yeah, and sorry, just to jump in, I mean, this is very much an open discussion, so it's about both topics, and you're absolutely right. I mean, you have a lot of valuable insight in terms of the prisons, and there's, of course, a lot of overlap in issues among the populations, but did you want to speak a little bit more about sort of special considerations in prison? You mentioned sort of peers.
Look, there has been some very interesting work that I've seen firsthand recently in Sydney and Australia and New South Wales, where the peer-based group there has been rolling out it's called FRI, Peer Harm Reduction in the Yard, and it's a very interesting program. What it's really shown is that, so sometimes, we talk about peer-led and peer-delivered programs, say in a prison context. Now, sometimes it might be more appropriate for that to be done by prisoners as peers in the peer context. But one of the things that's sort of showing from this program is that sometimes it might be better to bring peers in from who are not prisoners, but who are peers of injecting drug users into those environments for that, because prisons are a very particular kind of space. They're highly political, it's a really volatile environment. Criminalisation adds to the volatility of that environment, and the relationships between prisoners can be quite, there can be challenges in those relationships, and things people have to manage. So sometimes bringing in peers from the community can be a really good way of bridging that. And with that program, there's, for example, someone might come along to those sessions with the peers that come in from the user organisation, and then they'll go back to other prisoners and say, oh, look, you can trust those guys and they do know what they're talking about and you should really go and see them. So then the word of mouth spreads that way, and so building that trust and safety, even if people aren't sort of going along themselves in the first instance. I think peer-led and peer-delivered interventions in prisons can be particularly useful too, because of the short sentences that people who inject drugs, or drug offenders who are there on drug-related offences, can be often on very short sentences, can be coming in and out of prisons, and so sometimes people might start an initial conversation in prison, but it may not transpire, say around treatment, for example, that it happens while they're in prison or completely happens while they're in prison. So peer-led and peer-delivered interventions can be a really nice way to ensure those linkages through to post-release, and that relationships that they can trust and feel safe in, talk about what's really happening for them, can continue outside of being in prison as well.
Okay, thank you very much, Annie. My next question goes to Karin Timmermans from United. We heard a lot about synergies between the fields of HIV, hepatitis C, among people who inject drugs. Where do you see the biggest potential for synergies in this field?
Thank you very much for that question. I think that's a big one, and I'm also not fully sure that I'm the best person in this room to talk about that. I think one area of synergies that I see, and I'm bringing it maybe a little bit to the area that we as Unitate work on and know best, which is products. I think there are synergies or needs for synergies with regard to simplification of the systems, of the models of care, of making sure that it's easy for people to access services, as many others in the panel have referred to. And I think that is an area where I'm not sure if that would qualify as a synergy, but I think there's definitely lessons from HIV that we can and I think do learn in hepatitis C, and that may enable us to go a little bit faster. We can maybe skip some of the things that have been tried and failed in other diseases. I also think And again, I'm not fully sure if it qualifies as synergy, but the need for and the importance of having the right products, and so the need for innovation in products, in approaches, I think is important. One example that somewhat was alluded to Niklas in his presentation is we at Unitate have worked with partners to introduce HIV self-tests, which was, I think, at some point people were questioning whether that was a good idea, whether it could work. We've supported some of the work to demonstrate in HIV that it can work, that it does work, that it helps you to find additional people. And we are now really working with FIND and other partners to sort of replicate that with hepatitis C self-test. And we're also working and going to work and working at this point in other diagnostic innovations, whether it's diagnostic products or the algorithms to use them. And I think that is maybe one important, well, synergy, or at least an example of where we use lessons from other diseases.
Okay, thank you very much. My last question to Ernst Wiese from Médecins du Monde. Where do you see, more from a global perspective, the biggest challenges in achieving these elimination goals that have been presented by Niklas?
First of all, it was supposed to be my colleague Mintit from Myanmar sitting here, so just want to note, I feel a bit embarrassed to sit here with my white privileged European passport, but you'll have to take up with me for the moment. Thank you for the question. I mean, wow, talking about challenges, I think we can sit here till late at night, but one of the things probably that comes to my mind first is, as long as people who use drugs are not treated equally as people, I think we will always be struggling. And of course, I mean, many of us here in the room, we're all really nerds and we love new tools and new things and new models, and every time we think this is going to make the big change, but a lot of these tools are addressing symptoms and not the actual cause, the actual problem. So for me, that would be one of the core things when you talk about the challenges. I also might perhaps just want to make a small comment on opportunities. When you asked the question earlier on synergies, one of the things that I thought bringing is the word integration. We talk a lot about integration, HIV and hepatitis C, and I just wanted to give an example of one of our programs in Myanmar, because sometimes it's a very abstract word, we're going to integrate. I remember like 4 years ago, one of our programs in Myanmar, they have a big HIV program. There's a lot of issues, there's a lot of work, and most of the time we feel we don't cover enough and we don't do enough. So 4 years ago, the program, the team came to the HQ and say, look, we want to also now add hepatitis C. And to be honest, I was like, oh my God, honestly, guys, we can't handle overdose. We hardly manage to get treatment to people. There's a lot of villages that we don't even reach. Why do you want to add an additional disease to it? Of course, they won the argument, as they should, and I think they were extremely right, because once we started integrating hepatitis C within a HIV response, honestly, I think we added just a few staff. Like, if you look in our program, we have probably 250 staff. We might have added, I don't know, 8 people max, and of course you need treatment, but for the rest of it, it's almost like a complete free additional component within your program. I think there's a tremendous opportunity, and maybe this is just something that will bring you an initial step, and it might not get you to elimination. But I think there's a lot of opportunities in that area. And as Niklas also showed on the slides, now with Global Fund having the opportunity of including hepatitis C, I urge everyone, and including myself, because we often forget about it, we should really integrate a hepatitis C component if you have already this HIV system in place.
Thank you very much. I think we are at the time to close this interesting session, and I would like to close it with, firstly, thank you all for participating, to panelists and our speakers, and my co-chair Natasha. And I would like to close it also with a personal remark. I'm very thankful for this new guidance and new strategy of the WHO. I think this is a very important step, as we, from the example of Switzerland, but also many other countries that have very elaborated programs and measures against HIV, and they fight to integrate HIV. I think this is a very strong argument for those fighting to integrate hepatitis in the national HIV programs. Thank you very much, the WHO, for having this holistic and synergistic program and strategy launched. And thank you, everybody, for participating. And now I guess everybody is invited for the welcome reception and poster viewing in the exposition hall. Thank you.